Slide 1 and 2. Hello and welcome to week 2 and lecture 7. Today we are going to discuss about prehabilitation in knee injuries. The objective of today's lecture are 1 is to define prehabilitation and understand its role in knee injuries. Secondly, we are going to talk about the physiological rationale of prehabilitation before the surgery. We are also going to identify the key objectives and outcomes of prehab, and we are going to understand how prehab impacts surgical outcomes and long term recovery in knee injuries. We start off with the introduction. The concept of prehabilitation emerged in the late 20th century. It initially started with the oncological and orthopedic patients, and it was designed to improve the physical and functional reserves before a major surgical intervention. It was initially seen as an extension of principles of rehabilitation. But as time progressed, and nowadays rehabilitation is so common, especially in the athletic population, that rehabilitation is now considered an extension of rehabilitation principles. After applying the rehabilitation or the so called rehabilitation principles, it was observed that the athletes or the patients they recovered faster with better outcomes, and they had less post-operative disability. So let's discuss what is rehabilitation. How do we define it in terms of sports medicine context? When we talk about rehabilitation, we mean a structured and a targeted exercise protocol and education of the patient before the surgery. Rehab can also mean an early intervention in the conservative phase after a knee injury. The difference between rehabilitation and rehabilitation is that rehabilitation is a reactive process. It occurs when a patient has sustained a major knee injury or has undergone a surgery. But prehabilitation is a proactive process. Here, you prepare the patient's body, the mind, and the joint for what's coming. The timing of a prehab is sometimes before surgery, and sometimes it can act as a standalone management itself. To make you understand better, I'd like to give an example. The example is that of a ACL tear. Now, suppose an individual has sustained an ACL tear. This person will undergo prehab before the surgery or while he is waiting for the surgery. But in cases of degenerative meniscus injury, sometimes the prehab itself will cause the symptoms of the patients to reduce, and there will be no other surgery required for this patient. Why rehabilitation matters? Knee injuries often lead to a period of reduced activity, either consciously or subconsciously. This quickly results in deconditioning of the body, weaker muscles, restricted motion, and even loss of cardiovascular fitness. Prehabilitation prevents this decline. It helps to improve muscle strength and range of motion, which translates into fewer complications after surgery. Importantly, it also improves the psychological readiness. A patient who enters the surgery stronger and more confident often leaves the recovery process faster and more successfully. So, let's now discuss the physiological rationale about the muscle strength in prehab. Now, anyone of us who has ever worked with a rehabilitation of a knee injury of any patient knows that quadriceps atrophy is one of the most common problems before and after knee surgery, especially after ACL tear. Rehabilitation focuses on keeping the quadriceps, the hamstring, and the glutes active. Regular strengthening exercises not only maintains the muscle bulk, but they also improve the neural drive. Now, the neural drive is the ability of the brain and spinal cord to recruit muscle fibers effectively. This reduces the strength gap seen after surgery and accelerates the functional recovery of the patient. We will now discuss about joint mobility and range of motion. A stiff knee before surgery means a stiffer knee out after the surgery. Rehabilitation maintains the mobility and prevents contracture formation. Restoring full knee extension before ACL surgery is a key predictor of the outcome of the prognosis after the knee injury. By keeping synovial fluid circulating through gentle mobility exercises, we nourish the cartilage and improve the joint health. The proprioception receptors in a joint is destroyed because of any injury sustained by an individual. Because of the range of motion and mobility exercises of the joint, this um, improves the proprioception receptor and the feedback to the brain and improves the joint position sense, which is essential for dynamic stability. Let's discuss neuromuscular control. Knee injuries disrupt proprioceptive input, as discussed before, but this leads to an impaired balance and altered movement patterns. Rehab retrains the neuromuscular system uh, with exercises like single leg balance, perturbation training, and close chain kinetic movements. We enhance the body's ability to stabilize the knee in dynamic situations. This reduces the reliance on hip and ankle joint for compensatory movements, and it also lowers the risk of re injury once the athlete returns back to sport or activity. Another overlooked aspect of rehabilitation is maintaining cardiovascular fitness. Cardiovascular fitness is very important for a rehabilitating athlete or individual. Simple interventions like stationary cycling, pool workouts, or elliptical training help preserve the aerobic capacity of the individual. Better aerobic fitness reduces surgical risk and enhances wound healing. Similarly, patients with optimized BMI and lower systemic inflammation recover faster. So, essentially, rehab creates a healthy metabolic environment for both surgery and healing. The clinical goals of rehabilitation are very straightforward. It strengthens the muscles, improves joint mobility, minimizes swelling and pain, and restores a normal gait pattern. By doing this, we reduce complications like arthrofibrosis. Arthrofibrosis is formation of fibrotic tissue in joints, leading to incomplete and painful range of motion. We can also reduce complications like prolonged limping or chronic weakness of the muscles of the lower limb. A key element is also patient education. By teaching them the exercises and routines that they'll need after the surgery, they feel confident and have better compliance. Prehabilitation isn't just physical, it's psychological as well. Fear of surgery, the anxiety about recovery, and unrealistic expectations, all of these can undermine the outcomes after surgery or rehabilitation. Structured prehab programs include patient counseling as well. It helps patient with goal setting and gives them a reassurance about the prehab protocol that they have undertaken. This helps to build confidence, reduces fear of movement, and gives patient a sense of control. By setting realistic expectations, we prevent disappointment and promote adherence to post-op rehabilitation protocol. Now, enough said about prehabilitation, but what does the research and evidence say? The evidence strongly supports prehabilitation. In ACL reconstruction, especially, randomized controlled trials show reduced post-operative strength deficits and quicker return to activity. In meniscus surgery, pre-op training accelerates recovery of function. In TKR, total knee replacement surgeries, rehabilitation reduces hospital stay and speeds up a return to independent mobility of individuals. The systemic reviews, such as the BMJ Open 2016 meta analysis, which is a journal by the British Medical Association, shows that the prehabilitation is very cost effective, meaning it shows better outcomes without extra burden on the healthcare system. So, what do prehabilitation program look like? Strength training typically includes closed chain kinetic exercises of the lower limb, targeting muscles like quadriceps, hamstrings, your glutes, and calf. Mobility drills restore the range of motion of the knee, especially focusing on terminal knee extension. Neuromuscular training includes balance exercises, perturbation training, and movement retraining. Finally, low impact aerobic work like static cycling or swimming maintains cardiovascular fitness without stressing the injured knee. The key is individualized programming based on injury. The key is individualized programming based on injury type, timing, and patient goals. To conclude, rehabilitation is proactive care. It helps to prepare an individual for what is coming. The physiological rationale includes muscle strength, improving the knee range of movement, the neuromuscular training of the individual, and the cardiovascular fitness. Objectives are functional, clinical, as well as psychological. And there's very strong evidence for a better patient outcome post surgery for individuals who have undergone rehabilitation. With this, we will conclude this chapter. These are few of the references that I have discussed in this lecture before. Thank you. See you in the next class.